Dr. Gyanchand. Yeah.
Good afternoon, everyone. I will be presenting the paper on outcomes of GAT combined with phacoemulsification in primary angle closure glaucoma. I have no financial disclosure. Primary angle closure glaucoma is considered more aggressive than primary open angle glaucoma as it has contributed higher rate of blindness. Although trabeculectomy is the standard surgical option, but it is often associated with various vision-threatening complications. Minimally invasive glaucoma surgery offers a broader, lesser invasive spectrum of surgical options for glaucoma management, and GAT has demonstrated safety and efficacy in POAG, but its role in PACG is limited. The persisting iridotrabecular contact and peripheral anterior synecdoche has provided good rationale for performing GAT in PACG. The purpose of a study was to evaluate the surgical outcomes of GAT combined with phacoemulsification in primary angle closure glaucoma. It was a prospective interventional study, included 84 eyes of 74 patients. Institutional ethics committee approval was taken and written and informed consent was taken. Patients with pre-treatment IOP greater than 21 mmHg on gonioscopy greater than 180-degree ITC contact and with glaucomatous disc damage were included, and the data were evaluated for 2 weeks, 1 month, 3 and 6 months. Outcome measures were evaluated in the terms of intraocular pressure, anti-glaucoma medication, best corrected visual acuity, surgical success and any complications or interventions. Patients refractory to maximum medical therapy showing the severity of visual field defect with significantly visual cataract and status post-peripheral PI were included, and patients with any history of prior ocular surgery or trauma, monoocular patients, acute angle closure glaucoma, neovascular glaucoma and on anticoagulants were not included. So this is a video showing GAT combined with phaco was done in PACG group. Some patients had pass in the nasal angle, so goniosynecdosis was performed with spatula. Then with MVR blade, 1 to 2 mm goniotomy incision was given. And then the blunted tip of ioproline suture was inserted into the Schlem's canal to complete 360-degree trabeculectomy. Coming to results, data were analyzed using Strata statistical software version 17.0 and an alpha level of 0.05 and 80% of power. The sample size required were 84 eyes. Success criteria were defined on complete success, which included criteria 1 and 2, IOP greater than 5 and less than or equal to 21 and 18, and more than 20% reduction and 25% reduction from baseline without any AGM. Qualified success were defined achieving success with AGM, and failure was defined inability to meet the criteria for success or requiring any additional glaucoma surgery. So these are the demographic characteristics of the patient with baseline IOP of 21.13 mmHg and baseline AGM 1.93. So the IOP significantly reduced from 21.13 to 12.65 with 34.9% of IOP reduction at the end of 6 months, and AGM significantly reduced from 1.93 to 0.17 at end of 6 months. BCVA improved at the last follow-up. The cumulative probability of success by criteria 1 and 2 was 86.9% and 73.8%. These are the KM plots by criteria 1 and 2. And 2 patients had microhyphema, out of which 1 required AC wash. Coming to discussions, various studies have shown favorable outcomes of GAT in POAG, but the literature is limited for the outcomes of GAT in PACG. But recently, the GAT has shown promising outcomes of GAT in PACG also, and data were comparable with other study group. So the limitation of a study, it was a shorter duration of follow-up. Visual fields were not analyzed on follow-up. Quantification of peripheral anterior synecdoche was not done, and it included only Indian eyes. To conclude, GAT combined with phacoemulsification is safe and efficacious procedure in patients with primary angle closure glaucoma. It significantly reduces intraocular pressure and anti-glaucoma medication with good surgical success and rare vision-threatening complications. These are my references. Thank you.
What were the complications that you got when you are doing this procedure?
Sir,
GAT, mostly.
Yes, sir. So microhyphemas are seen in almost all patients, but they are usually self-resolving by 1 week or 2 weeks. And major complications like macrohyphema are seen, but if they are non-resolving, and causing decrease in vision, increase in IOP, we take them for AC wash.
Immediately on the table, what is the thing that you adopt if it's a macro hemorrhage?
Sorry, sir?
Macro hemorrhage on table, what is the first step that you do?
So, the most weapons for performing any minimally invasive glaucoma surgery is high density viscoelastic, cohesive viscoelastic. So, whenever there is bleeding, we can use and the bleeding stops. Basically, we want to increase the eye pressure. So, when the eye pressure is increased, there is stop of the reflex from the Schlem's canal, and then the bleeding stops, and then we can perform.
Yeah, generally they say inject a hyperviscoelastic and then take a coffee break.
So how can you include the patient in the, according to the synechiae or all angle closure glaucoma?
So patients with only acute angle closure glaucoma were excluded. Patients with synechiae also on gonioscopy.
Synechiae 360 degree or at one quadrant only or through one?
So 360 degree were also included, but they didn't show good results. And if the patient had nasal synechiae, we did GSL, goniosynechialysis.
Because how can actually assess the all quadrant synechialysis? I don't know. It's very difficult.
So, but by performing GAT in PACG, it requires little more pressure to thread the suture because of the presence of synechiae.
No, actually you can show only the nasal side,
Yes.
your synechialysis, but in the superior side and other quadrant is...
So, when the suture is not going, then we can thread in anti-clockwise direction. So,
Okay.
we can do other side, 360 degree trabeculectomy, if it is not passing on the same side.
So you did the synechialysis in all quadrant?
No, sir. Only nasal quadrant, sir.
Only nasal quadrant.
Yes.
But when you actually release the suture, you can just tighten the suture, the all synechiae is not broken. Sometimes the iris is come out.
Sir,
It can
yes.
cause the iridodialysis and other things.
So actually, primary angle closure glaucoma have shown the results of iridodialysis, but it usually is seen where we give the main tunnel incision. But it is usually 1 to 2 clock hour, and it doesn't require any intervention.
It is very difficult. Okay.